83-year-old lady presented with acute coronary syndrome, and she is hypertensive, and she was on full medical therapy for her symptoms of coronary artery disease. But in spite of full medical therapy, she had a recurrent angina, and ECG shows T inversion in the anterior, changes in the anterior lead in the form of T inversion. So this lady actually, we did angiogram, showed very tight lesion in the LAD. You can see here. This is a very tight lesion in the LAD here, proximal LAD with a big aneurysm. You can see the giant aneurysm, followed by another lesions, which you can see in the other view. You can see here another lesion here, and about 2.2 millimeter diagonal arising from the aneurysm. And the septal is sitting just at the distal lesions. So now question is that what to do in this case, because she is now having a recurrent angina. She is in the hospital with recurrent ECG changes in spite of maximum medicine. Initially we are not very keen to do any intervention for this lady because of high risk, and she is a hypertensive, elderly, and definitely she has a bleeding score is high, and she had all chances of having complications like hematoma, bleeding complications. And you can see the aneurysm with this aneurysm with the lesions here, and if you see here, there is a heavy calcification near the aneurysm, with the proximal as well as distal lesions. So basically, this is a very elderly lady with comorbid conditions, with a high risk for bypass surgery, with a complex disease of the LAD, heavily calcified, with a big aneurysm. And on top of that, she has right coronary artery is totally occluded. So this is a kind of clinical situations. Now, question is that which intervention we should prefer. So in this lady, in fact, switching any kind of intervention is risky. Either bypass or angioplasty, both are equally risky. And attendants and relatives are not keen for surgery, and because of the risk involved with the surgery, we did consider, but they are not very keen for surgery. That's why we thought we will go for intervention. Now, question is that what way we should approach in this case. There are a lot of there is no specific recommendation for this kind of situation. Whether we should close the aneurysm with a cover stent, and we followed by another drug-eluting stent, or we should do a DEB followed by regular cover stent to close the aneurysm, or leave the aneurysm, put just concentrate on the lesion and put a stent. So these are the different kind of modalities we discussed. Finally, we have decided that we just forget about the aneurysm. We just modify the calcium using intravascular lithotripsy because it's a heavily calcified artery. Doing rotablation is not easy in this case. Can be done, but it is kind of not very advisable. Congenial condition here. So we thought we'll do IVL and modify the calcium followed by stenting across the aneurysm, and let us see the aneurysm what will happen. Hopefully it will collapse in due course, ultimately it will close. So that is the plan. Now this lady has got a very tortuous radial arteries and subclavian artery. So angiogram we did from the radial approach, but because of the tortuosity and spasm, we thought we should go for the femoral. In fact, in the femoral also we came across the same problem. You can see that there is a figure of 8 band in the iliac artery, which was really difficult to negotiate with a wire and also catheter. But subsequently, without putting a long sheet, we could pass the 7 French catheter, this guide catheter into the coronary artery. So finally, we could engage. You can see that this is a lesion here. And we again second difficulties in this patient is the crossing this lesion in a presence of aneurysm. So it was a little difficult. So you'll have to modify the wire. You'll have to make a loop. So you'll have to try to cross the distal lesion. So it is not easy to cross. It took some time to cross this lesion. Finally, we could cross with a wire, and After that, we are not able to send a wire beyond this because there is also calcification and tortuous LAD. If you see the LAD here, it is a quite tortuous and calcified. You can see the very tortuous calcified. Beyond this point, this wire is not going. You can see the RCA is also filling from here. So, but we'll have to somehow we'll need to try. We tried a lot with a balloon support, small balloon support, because big balloon is not cross, small balloon support, but still we are not able to cross the wire. But at the same time, we cannot lose the position of this wire because somehow we cross the aneurysm. So we could we could not send, but we parked the wire there itself. Try to put another wire. That wire also could not be crossed. So finally, I put it in the septal so that we can have little more support, a little bit, and we put it then. Cross the lesion, the 1.5 millimeter balloon with difficulties. You can see the calcium here, heavy calcification. Then pre-dilated the lesion with a 1.5. Then followed by 2.5 millimeter balloon we could cross with difficulty. You can see that balloon is not crossing. When you're trying to cross the balloon, it is coming out. So somehow you could cross, and you can see that it is not going. So we could cross and dilated the lesions. And this is the preparation to go for IVL, because IVL is a bulky balloon. So we need to have a good support, support, as well as you need to open the lesion so that bulky balloon will cross. That's what we did. And we do not have a good support of the wire. We could not pass the wire distally. So somehow we could manage. So we prepared the lesion with 2.5 NC balloon. Then finally we did, you can see that lesion modification. And finally you can see the waist here. This is the 2.75 balloon at 18 atmosphere. This balloon waist is not giving away. That means it is heavily calcified. This balloon is not opening with a very high pressure. So we need to modify this calcium with a IVL. So after this, IVL balloon could be passed, and it was a little difficult. So we put another body wire to pass the balloon here. You can see that body wire under the wire so that we can get a better support. Then we push this IVL balloon. You can see that IVL balloon. This is IVL balloon position here. Given a shock here 3 times, 3 cycle of shock we gave. You can see that waist totally disappeared, which was seen in a 2.75 millimeter balloon. This is disappeared now, and this approximately also a shock was given. This lesion was modified now. We are happy with that. That the lesion is open now with a IVL balloon. There is some waste, but this mild waste is left out. That is fine, but we have modified the calcium. Now you can see here there is mild waste is there in spite of repeated shock, but fairly acceptable with the IVL. Then finally we put a stent. This is the 3.5 into 28 millimeters stent, drug-eluting stent. And again we had some problem here. You can see that because of this tortuosity, there is a big kink was there, but somehow very carefully. That's the reason I just wanted to show you. Very carefully we pass the stent here. You can see that, so that stent will not get kind of traumatized in this area. So finally we positioned the stent. We deployed the stent, took out the other wire, and this was deployed at 18 atmosphere, subsequently dilated at 22 atmosphere with a 3.5 millimeter NC balloon, and proximal part of the lesion was dilated with this implantation of the drug-eluting stent. The post dilatation with a 3.5 millimeter balloon, and finally we have proximal part post dilated with a 3.75 millimeter balloon at 20 atmosphere. And you can see the final result. There is definitely a little bit of aneurysm already, sizes already has come down a little bit. There is some collapse of the aneurysm, and there is a good distal flow, diagonal is flowing, septal is flowing. I think this is acceptable at this point of time. We need to, of course, see the aneurysm, what will happen in future. So we need to continue dual antiplatelet therapy without any failure, and need to continue religiously, because this is the situation where there is nidus for thrombosis thrombus formation here. So we need to ensure that we need to continue dual antiplatelet therapy in this case without fail, and we have to keep a follow up with this lady. This is a final result. You can see here in this other view, there is no residual here. Of course, aneurysm is still there, but there is some kind of regression of the aneurysm size if you compare with the first view. And final result is acceptable. This lady, after 2 days, third day, today we are going to discharge the lady. She is completely fine. Plan is to continue dual antiplatelet therapy and with a close follow-up. Maybe electively we are planning to do an angiogram after 6 months. Thank you.